Hello. श्रीमान जी, जागृति मैडम को अनम्यूट करो ना, आपने सेंट्रली ये किया है क्या?
Madam has to do, madam. We don't have access to unmute. We can only mute.
Okay. So now am I audible?
हाँ मैडम,
Yes, ma'am.
Okay, so we'll start, right?
जस्ट अ मिनट. लोणकर सर नो फोन હતો.
Okay. Good evening, everyone. Hello. We'll start, Manji.
Good evening, ma'am.
Okay, Ajay.
જસ્ટ 1 મિનિટ મેડમ, જોઈન કરે છે. એક જ મિનિટ. We will start, madam. Jagruti madam.
Yes. Good evening, everyone. Greetings from Dr. Jagruti Desai, President, Surat Gynec Society, and Dr. Kajal Mangukia, Secretary, Surat Gynec Society. Welcome to one and all. Honorable President Foxy, Dr. Shanta Kumari, Secretary General, Dr. Madhuri Patil, Dr. Ajay Shrimanji, Dr. Kiran Mai, President of Valsad Gynec Society, Dr. Kuresha, Secretary Dr. Keyur Padalia, Vapi President Dr. Sheila Moria, Secretary Dr. Nikunj Nivadia, Navsari President Dr. Narendra Gajjar, Secretary Dr. Satyen Kasabwala. It gives me immense pleasure and honor to welcome you all to this unique session. It is a Foxy WHO joint initiative, RAC, Respectable Abortion Care Training Program. I appreciate you all for attending this program today. In a historic move to provide universal access reproductive health services, India amended the MTP Act 1971 to further empower women by providing comprehensive abortion care to all. The new MTP Act Amendment 2021 expand the access to safe and legal abortion services on therapeutic, eugenic, humanitarian, and social grounds to ensure universal access to comprehensive care. It is a step towards safety and well-being of the woman, as many women will be benefited by this. We have lots to cover today, so we really should begin now. The first module is Medical Termination of Pregnancy, MTP Amendment Act 2021, Respectful Abortion Care, RAC. Joint Foxy and WHO initiative. So in module 1, we'll be talking about evidence dissemination. We will take a closer look at what are the new laws and what are the changes in the rules. Unsafe abortions in India leads to mortality, morbidity, and hamper women and girls' full participation. 8% of maternal deaths per year due to abortions. It is the third leading cause of MMR. Nearly 2 out of 3 of the abortions performed are deemed unsafe. Nearly half of the pregnancy-related deaths are in women and girls under the age of 24 years. The World Health Organization says, when is abortion considered safe? According to WHO definition of safe abortion, when it is done by appropriate methods and by trained persons. If it is safe, if both the criteria are met, it is less safe if only one of the criteria is met, and it is unsafe and both criteria are not met. So medical termination of pregnancy amendment 2021, safe and comprehensive care mandated by law. Modification is requirement of the provider. It says, according to the previous act, there was requirement of opinion of one provider for MTP up to 12 weeks. According to the 2021 amendment, requirement for opinion of one registered medical practitioner for termination of pregnancy up to 20 weeks of gestation. Previously, requirement of opinion of 2 providers for MTP for 12 to 20 weeks. And now it is requirement of opinion of 2 RMPs for termination of pregnancy 20 to 24 weeks of gestation. So the potential outcome because of this new amendment, it is increasing number of facilities, especially in public sector like PHCs, eligible for service provision till 20 weeks. Modification for vulnerable group of women. Previously, according to the previous act, MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. According to 2021 amendment, enhance the upper gestation limit from 20 to 24 weeks for special vulnerable categories of women, and further enhancement for birth defects not compatible with life on medical board consensus. So the potential outcome out of this is there is an increased access for vulnerable women to safe and legal abortion services defined by the Rules Committee, includes violence victims, minors, among others. Modification for birth defects and congenital anomalies. Previously, the Act had provision for termination of such pregnancies only up to 20 weeks. And according to the new amendment of 2021, the upper gestation limit does not apply in cases of pregnancies with substantial fetal abnormalities diagnosed by a medical board. The potential outcome out of this is there is increase in access to safe and legal abortion services, who often seek service late beyond legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late, thus reducing unsafe abortions and court cases. Many times the patient doesn't come for sonography and at 12 weeks or at 20 weeks, but maybe at 7 to 8 weeks, 8 months, and then this is useful if she has an abnormal child. Modification related to marital status. According to the previous act, the condition of failure of contraceptive was applicable only for married women or her husband. According to the 2021 Amendment Act, condition of failure of contraceptive to be extended for any woman or her partner. So the potential outcome from this is there is an increased access to safe and legal abortion for any woman, irrespective of marriage age, especially with upcoming changes in legal age of marriage, an important advancement for increasing access to safe abortion. Insertion of new clause for strengthening privacy. Previously, the Medical Termination of Pregnancy Regulation 2003 mentioned that information should not be disclosed except on the authority of law. According to there is a new insertion in 2021. Here, the name and other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. So the potential outcome is there is increase in privacy and confidentiality of the abortion seekers, increased demand, but need to safeguard rights and dignity of women and provide respectful bias-free services, including counseling and contraception. So, MTP Amendment 2021, it prioritizes confidentiality and safety, name and other particulars of any woman seeking abortion to be confidential, except to a person authorized in any law for the time being in force. The ground of failure of contraceptive has been extended to the women and her partner. Now, the rules under MTP Amendment 2021, number 1 is it defines special or vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. Number 2, the norms for the registered medical practitioner, that is RMP, whose opinion is required for termination of pregnancy at different gestational age. Number 3, the powers and functions of the medical boards, OBGY and the pediatrician, plus the radiologist, when available, formed for each state and mandated to provide timely evidence-based decisions. Rules under MTP Amendment 2021. Number 1, special category of women eligible for MTP between 20 and 24 weeks. So these women will be, number 1, that is the survivors of sexual assault, rape, incest. Number 2, all women with pregnancy in humanitarian settings, by disaster and or emergency situations as declared by the government. Number 3, change of marital status during the ongoing pregnancy, that is widowhood and divorce. Number 4, women with physical disabilities, major disability as per criteria under the Disability Act. Number 5, mentally ill women, including mental retardation. Number 6, the minors. Number 7, fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. Norms for the RMP. RMP is defined in the old Act as MBBS or more with any medical practitioner who has assisted 25 cases of MTP, of which at least 5 done independently in a hospital. Those medical practitioner who has completed 6 months of house training in OBGY, medical practitioner who holds a postgraduate degree or a diploma in OBGY, and a medical practitioner who has experience of at least 1 year in the practice of OBGY. So 1 RMP opinion up to 20 weeks of gestation, 2 RMP from 20 to 24 weeks, and medical board opinion is required if it is beyond 24 weeks. So norms for the RMP. Under the amended rules 2021, an additional category of provider has been added for termination up to 9 weeks with medical methods. RMP with experience in the practice of OBGY at any hospital for 3 months, or those RMP who has training with performance of 10 cases of MTP by MMA under supervision of an RMP in a hospital established or maintained or a training institute approved for this purpose by the government. So 1 RMP opinion up to 20 weeks of gestation, 2 RMP 20 to 24 weeks of gestation, and a medical board is required if opinion is required if beyond 24 weeks. So the norms for the RMP whose opinion is required for termination of pregnancy at different gestational age. Till 9 weeks, experience and training required for RMP. As we already discussed, experience at any hospital, 3 months in practice of OBGY, or who has independently performed 10 cases of MTP. Number 2 is a practitioner who has assisted a RMP in the performance of 25 cases of MTP, or of which at least 5 have been done independently in a hospital. Number 3, a practitioner who holds a PG degree in gynec. A practitioner, number 4, is a practitioner who has completed 6 months of house training in OBGY, and a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of OBGYN. So opinion of only one RMP is required. The norms for RMP whose opinion is required for termination of pregnancy at different gestational age, that is till 12 weeks, experience and training requirement is one who has assisted in the performance of 25 cases of MTP, of which at least 5 have been done independently. Number 2, a practitioner who has a postgraduate degree or a diploma in OBGYN. Number 3 is a practitioner who has completed 6 months of training. Number 4 is a practitioner who has experience at least at any hospital for a period of less than 1 year in practice of OBGYN. Opinion of one RMP is required, that is less than 12 weeks. So up to 12 weeks, less than one RMP opinion is required. Now beyond 12 weeks till 20 weeks, experience and training requirement for RMP is a practitioner who holds a postgraduate degree in a diploma, that is diploma or a degree in OBGYN, a practitioner who has completed 6 months of house training in OBGYN, a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of OBGYN, opinion of one RMP is required. Between 20 to 24 weeks, experience and training requirement for RMP. Number 1 is a practitioner who holds a PG degree in OBGYN. Number 2, a practitioner who has completed 6 months of house training in OBGYN. And number 3, a practitioner who has experience at any hospital for a period of not less than 1 year in OBGYN. Opinion of 2 RMPs is required. So beyond 24 weeks, experience and training requirement for RMP is a practitioner who has a PG degree or a diploma degree in OBGYN. And number 2 is a practitioner who has experience at any hospital for a period of not less than 1 year in OBGYN. So here the opinion of a medical board is required for the termination procedure when advised by the medical board is carried out with all safety precautions along with appropriate counseling at an approved place. So this is composition of the number 3, that is composition of the medical board: a gynecologist, a pediatrician, a radiologist, or a sonologist. So the powers of the medical board, they are: number 1, to allow or deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuing that the procedure would be safe for the woman at that gestational age, and whether the fetal malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. Co-opt other specialties in the board and ask for any additional investigations if required for deciding on the termination of pregnancy. To be noted is FOXI with ministry guidance and WHO support as part of RAC can operationalize enhanced medical board information on website. So functions of the medical boards: to examine the woman and her reports who would approach for medical termination of pregnancy. Number 2 is provide the opinion of medical boards informally with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical termination of pregnancy. And number 3 is to ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of the request for MTP. Now remember, FOXI has an important role to play in ensuring there are functional medical boards in every state, as is stated in MTP Amendment 2021. So this is all. Registration and pre-test, post-test and feedback is absolutely necessary, and a certificate will be awarded to all the participants on attending the training and submission of registration, pre-test, post-test, feedback. So in India, abortion is legal Let us make it safe and responsible. Thank you so much. I hand over to Dr. Kajal Mangukia. She will carry on further. Kajal?
Yes, thank you so much, Jagruti madam.
I'll stop sharing.
Yes, yes, madam. The screen is visualized. You can see the screen?
Yes, ma'am.
Okay. So thank
Yes,
you,
yes.
Dr. Jagruti madam, for giving all the details regarding the rules and regulation and the amendment of MTP Act 2021. So moving further with the safe abortion values, evidence, rights and respect.
Madam, sorry to interrupt you. Madam,
Yeah.
click on this enable editing first, which is
Sorry?
there. Enable editing, madam. Click on the enable editing.
Yeah, sorry to interrupt you all. This is module 3 going on, Dr.
Yeah.
Kajal.
Yes.
Kajal, you have to go on with the module 2.
Module 2.
Yes, module 2, please. You are muted, Dr. Kajal.
Hello. Just a minute. Yes.
Yes.
So now moving further, module 2, that is safe abortion updates in technology. So I just want to highlight that safe abortion practice is a very, very important, as we must have heard somewhere that, there is a young, even the girls, the unwanted pregnancy, or there is a quacks which are there surrounding. So, the method of DNC is done, and we have seen that there is a perforation and the intestine and everything is damaged so badly, which creates a life-threatening issues for the pregnant mothers. So it is very important to conduct a safe abortion practice. So this session, we will be viewing the existing guidelines, the pre-abortion assessment, which is a very, very important step, the medical methods of abortion and the surgical methods of abortion.
Madam, sorry to interrupt you. Madam, it's still showing in PPT only, madam. Click on enable editing first, the top.
Sorry?
Click on this enable editing, madam, at the top of your screen. Then go to slideshow, ma'am. Click on from current slide.
Yes. Now it is okay?
Yes, ma'am.
Yes.
Yeah. So WHO Global Guidelines on Safe Abortion, Clinical Practice Handbook for Safe Abortion, Technical and Policy Guidance for the Health System, Medical Management of Abortion, and Health Workers' Roles in Providing Safe Abortion Care and Post-Abortion Contraception. So WHO National Publications on Safe Abortion. So in 2012 to 2019, you can see this is a roadmap to WHO Safe Abortion Guidelines. 2014, it is a Clinical Practice Handbook for Safe Abortion. 2015, it is a health worker role in providing safe abortion care and post-abortion contraception. 2018, it is a Medical Methods of Abortion Guidelines. 2019, it is WHO Consolidated Guidelines on the self-care intervention for health. So this is a further historic change in 2021. there is a medical termination of pregnancy amendment 2021, which is a comprehensive care mandated by law. So these are the changing in the rules. All the guidelines have three key areas in management of abortion safely. It is a pre-abortion care, the abortion method, and the follow-up and the aftercare, including the post-abortion contraception and counseling. So here you can see that first comes is the medical history. So history taking is very important. Then comes is the physical examination, then the required blood investigation, laboratory and other investigation, discussing about the contraceptive options, decision making. If the woman chooses to have an abortion, she should be allowed to choose from among the available methods that are appropriate for her based on the duration of her pregnancy and her medical condition. So what is there in the pre-abortion assessment and counseling? So what are the components of pre-abortion assessment for women seeking first trimester abortion? Detailed history taking, general physical and pelvic examination, laboratory and other investigation, and at the end comes the decision making information on abortion procedure and counseling regarding the contraceptive methods. Gestational age determined by the LMP or physical examination. As we all are aware about this diagram or this picture, that uterine size in weeks, after 4 weeks of gestation, the uterus increases in size by approximately 1 centimeter per week. And after 12 weeks of gestation, the uterus rises out of the pelvis. Generally nowadays, majority of the practitioners are using sonography. So we can see in the sonography also at 6 to 8 weeks that there is a gestational sac, and we can calculate from the CRL that how many weeks of pregnancy is there. Then after 15 to 16 weeks of gestation, the uterus reaches the midpoint between the symphysis pubis and the umbilicus. At 20 weeks of gestation, fundal height in centimeters measured from the symphysis pubis appropriate the weeks of gestation. So pre-abortion investigation, routine lab test not a prerequisite for abortion services. Test that may be performed as per individual risk factor on finding of physical examination are pregnancy test if pregnancy is not yet confirmed, hemoglobin or hematocrit for the suspected anemia, RH testing where RH immunoglobulin is available for RH negative women, HIV testing and counseling for the same, STI screening usually performed during the pelvic examination, and other laboratory tests as indicated by the medical history depending upon the kidney and the liver function test. Ultrasound is not necessary unless to diagnose of pregnancy is not certain or suspecting ectopic or a missed abortion. Pre-abortion counseling, thought about terminating the pregnancy. So we need to ask her about what is the reason for termination. We have to take inform about early abortion, whether it is safe, importance of a trained provider performing the procedure for safety, available methods of abortion. We have to do a counseling for that, risk and warning signs associated with the abortion methods. What are the consequences? What are the risks involved for the medical termination? What are the risks involved for the surgical termination? Without contraception, she can get pregnant as soon as 14 days after an abortion, resumption of her normal activities, including sexual intercourse and any other follow-up care. We need to document about the informed written consent, decision to accept post-abortion contraceptive. Even if she is not willing for the contraception, she will be provided with the abortion services. So clinical management of abortion, abortion care less than 12 weeks, generally global recommendation is mifepristone and misoprostol, misoprostol only and vacuum aspiration. More than 12 weeks, global recommendation is mifepristone and misoprostol, misoprostol only and dilatation and evacuation. Not recommended is dilatation, DNC, so it is dilatation and a sharp curettage. So GUI recommendation, medical termination until 9 weeks only. So here we can see that normally what we do is if it is the pregnancy is up to 7 weeks, that is 49 days, Mifepristone 200 milligram orally is given. Wait for 24 to 48 hours. Then misoprostol 800 micrograms sublingually, buccally, vaginally, or by oral route. If the pregnancy is between 7 to 9 weeks, that is 49 to 63 days, mifepristone 200 milligram orally, same protocol as we have discussed in up to 7 weeks. Clinical management of abortion, we have medical methods of first trimester abortion and surgical method, that is manual vacuum aspiration and evacuation. Tablet mifepristone and tablet misoprostol. Mifepristone is an anti-progesterone which inhibits the action of progesterone. It interferes with the continuation of pregnancy. Initial oral dose of mifepristone followed by misoprostol, which is a prostaglandin E1 analog. Misoprostol causes cervical softening, uterine contraction, and expulsion of products of conception. What are the advantages of tablet misoprostol? Protocols for mifepristone and misoprostol on day 1, which we just discussed, that we give mifepristone. On day 3, mifepristone misoprostol administration is given. If she is a RH negative, we need to give NTD up to 7 weeks, which we discussed. The same protocol is used. In addition, if she is having abdominal cramps, we can advise her to take analgesic, antiemetic, and we can offer a contraception after that. Within day 15, follow-up is advised. We need to confirm and ensure completion of the procedure. Offer her contraception if not already done previously. What are the characteristics of different routes of misoprostol administration? Administration for the first trimester abortion. Orally, pills are swallowed. Recommended up to 7 weeks for the first trimester abortion. What are the side effects? Diarrhea, shivering, nausea, fever, and chills. Buccal root, which is placed between the gums and the cheek and swallowed after 30 minutes. More fever and chills than the vaginal route. Generally, we all prefer majority vaginal or oral route. Sublingual pills are placed under the tongue and swallowed after 30 minutes. Increased fever, chills, diarrhea, and vomiting compared to the vaginal route, which is a fastest onset of action and highest plasma concentration level, that is sublingual. Vaginal pills are placed in the vaginal fornices, deepest portion of the vagina, and the woman is instructed to lie down for 30 minutes. These pills fragments may be visible, lowest rate of side effects. Here you can see the diagram, buccal and sublingual route of misoprostol administration. WHO drug regimes, dose schedule for medical termination, 200 milligram of mifepristone and 800 microgram of misoprostol. Vaginal bleeding for 2 weeks is normal after medical abortion. Such bleeding can last up to 45 days in rare cases. Provision of MMA services. Services should be available at the primary care level with a referral system in place for all the required higher level care. Additional services may need to be provided to individuals seeking medical abortion, like counseling and testing for the sexually transmitted infection, abuse support services, psychological or social services, or other specialist health or medical services. Provide the iron tablets for anemia if required, provide any necessary pain medication, and provide emotional support if needed. Sources: Medical Management of Abortion, WHO 2018. Now comes is the follow-up care. Routine follow-up not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, or address any medical concern. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess the success of abortion. Follow-up care: assess the woman's recovery and ask for any signs or symptoms of ongoing pregnancy. Review any available medical records and referral documents. Ask about any symptoms experienced since the procedure. Perform a focused physical examination for any other complaint. Assess woman's fertility goals and need for contraceptive services if not provided earlier. So this is a MMA summary. First visit, what all need to be done? Physical and pelvic examination, confirm the eligibility, how many weeks of pregnancy, tablet mifepristone, offer NTD 50 microgram to Rh negative woman. Tell the woman return for misoprostol administration after 2 days, 48 hours after that. Contact address and phone number of the facility center where she can go in case of any emergency. Record her experience of any side effects on the MMA card. 3% women may expel completely with mifepristone alone, but misoprostol schedule should be completed. This is a very important while giving the first dose or on first day visit. We need to counsel this also. On second visit, that is on day 3, what to do? Give a misoprostol 400 micrograms sublingual, buccal, vaginal or oral. Observe for 4 hours. Analgesics such as ibuprofen 400 milligram and contraceptive options like condom, hormonal methods, oral or injectable. Tell the woman mean period of bleeding is 8 to 13 days. Possible side effects like nausea, vomiting, diarrhea, headache, fever, dizziness can occur. Report in case of any excessive bleeding, pain in abdomen and fever. Report if there is no bleeding. 24 hours after misoprostol, consider giving additional dose of misoprostol. 75% of the women abort within 4 to 6 hours after misoprostol administration. On third visit, that is on day 15, pelvic examination to ensure the completion of abortion, contraception options like hormonal, oral, condom, IUCD, sterilization after 1 menstrual cycle. Tell the woman about immediate return of fertility. Report back if there are no periods within 6 weeks of completion of the abortion process. USG only if examination does not confirm the completion of procedure. What are the side effects and complication? Pain, respectful, non-judgmental communication, verbal support we need to give. Adequate counseling plays a very important role. Support person, ibuprofen 400 milligram, persistent pain with failure to respond to these drugs for several hours. Warrants evaluation for other causes such as ectopic pregnancy, infection or incomplete abortion. Nausea and vomiting is self-limiting. We have to just give a reassurance. Diarrhea, self-limiting, reassure mostly because of misoprostol. Infection confirmed by physical examination and start antibiotics. Action for failure or incomplete result. Failure of medical method of abortion, we offer a vacuum aspiration or repeat MMA. Incomplete result of MMA, we can observe unless heavy bleeding has started. If the bleeding has resolved, uterus is normal size, that means abortion is complete. If we observe unless heavy bleeding, there is a heavy bleeding which is continuous, then we can offer her surgical method of evacuation. Excessive bleeding per vaginum. Woman presents with the excessive bleeding per vaginum, bleeding more than her menstrual cycle, soaking 2 pads in 1 hour for 2 consecutive hours. Bleeding decreases over time, then we need to give a routine care, keep a watch on her vitals and bleeding PV, she can go home. If the bleeding decreases, there is no decrease in the bleeding, we need to watch her vitals per vaginum examination. We have to rule out the POCs present in the cervical canal, digital evacuation. If the woman is stable and bleeding reduces, she can go home or we can just observe her for 1 more hour. If the bleeding continues, we need to advise her USG. If there is minimal decidual beats, we can wait and watch. If there is more POCs and decidual beats, woman is stable, we can again repeat misoprostol, either orally 600 microgram or 400 microgram sublingually. If she is not stable, we need to do a vacuum aspiration. And if continuation of pregnancy, we can go for vacuum aspiration. Recording and reporting of MMA. Since MMA comes under the purview of the MTP Act, the documentation is similar to that required for the vacuum aspiration procedure. It is mandatory to fill the following norms, that is Form C, consent form, Form 1, RMP opinion, Form 2, that is monthly reporting form to be sent to the district authorities, Form 3, that is the admission register for case records. What are the methods of first trimester abortion? That is a surgical methods. Surgical methods in first trimester, Vacuum aspiration is the recommended technique of surgical abortion for pregnancies up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method. The procedure should not be routinely completed by sharp curettage. Vacuum aspiration method. This is a manual vacuum aspiration instrument. Procedure of abortion performed is same regardless of the type of vacuum used. This is a handheld aspirator used to generate vacuum. Aspirator is attached to cannula of 4 to 12 millimeter in diameter. Cannula can be used in multiple settings, including those without electricity. IPS or easy grip cannula size corresponds with weeks of gestation. Example, 8 millimeter cannula for 8 weeks gestation and 10 millimeter for 10 weeks. And electric vacuum aspiration, an electric pump used to generate the vacuum, can accommodate cannula of manual vacuum aspiration with the correct size tubing. Cervical priming. This may be considered for women with a pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate. Recommended methods of cervical preparation before surgical abortion in the first trimester are oral mifepristone 200 mg 24 to 48 hours in advance, misoprostol 400 microgram administered sublingually 2 to 3 hours prior to the procedure, or misoprostol 400 administered vaginally 3 hours prior to the procedure, or laminaria placed intracervically 6 to 24 hours prior to the procedure. For the pain management, we can use important component of quality abortion care. We can give ibuprofen, meftalspas, which reduces pain and anxiety and makes the woman comfortable. We can have a pain management includes two things, that is non-pharmacological and pharmacological. So non-pharmacological is more of a giving a psychological support, explaining each step to the woman in advance, performing the procedure gently and smoothly, encouraging the woman to relax and breathe deeply. This is a pharmacological pain management plan. Sources of pain and its management. If there is anxiety, we can give anxiolytic or general anesthesia. Dose and timing, diazepam 10 mg orally 1 hour prior to the procedure, or 2 to 5 mg IV 20 minutes prior to the procedure. Duration of effect is 4 to 6 hours, and the side effects are disorientation and dizziness. Cervical dilatation with the local anesthesia or NSAID like ibuprofen. The dose of local anesthesia 10 ml 1% lignocaine, and for ibuprofen it is 400 to 800 milligram 1 hour prior to the procedure. The effect of local anesthesia lasts for 60 to 90 minutes, and that of ibuprofen is 4 to 6 hours. The side effects are dizziness, seizures, and gastritis. Uterine cramping, best is ibuprofen 400 to 800 milligram 1 hour prior to the procedure. The effect lasts for 4 to 6 hours, and side effect is gastritis. Now, what are the steps of manual vacuum aspiration? I already have this instrument, so I'm also using in few patients if required. Prepare the instrument. This you need to close the valve button, create a vacuum. So this is a manual vacuum which is created. Prepare the woman, ensure pain control medication is given at appropriate time, which we just discussed. Ask the woman to empty her bladder. Perform the cervical antiseptic preparation. We can administer the local anesthesia, that is a paracervical block, and then dilate the cervix and insert the cannula. Suction of the uterine contents. Withdraw the cannula 1 to 2 centimeter away from the fundus inside the uterine cavity to prevent the perforation. Rotate the cannula in 10 to 2 o'clock position with the smooth, gentle motion. Release the vacuum button on the aspirator. Signs that the uterus is empty: red or pink foam without the tissue passing through the cannula. Gritty sensation over the surface of the uterus. Cervix gripping over the cannula. Uterus contracting around the cannula and increased in the uterine cramping. Then we can inspect the tissue. Concurrent procedure. If she is ready for the further contraceptive devices like IUCD or sterilization, we can offer that. And instrument processing, instrument to be soaked in chlorine solution. Assist disinfection, helps remove the tissue and the body fluids. Post-procedure care. Monitor her for any complications and provide management as required. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that the woman has all the necessary information and medications prior to leaving the facility. Document all the outcomes of the treatment, including any adverse events in the facility registered and client's record card. Aftercare management of any abortion complication like incomplete abortion, infection, bleeding, ongoing pregnancy, provision of contraceptive information and offer contraceptive counseling methods, assessment of any other sexual and reproductive health needs that may require additional care, and follow up, no routine follow up unless misoprostol alone regime is used. That is a new recommendation. So in summary, India has made historic progress in improving access to safe abortion. Not much has changed in technological update in the last decades. As providers, it is up to us to ensure safety and quality, especially in context of the amended law. Along with the safety, we also need to focus on the respectful abortion services, as just now I described about the scenario. Event every client, public or private, an opportunity to inform, educate, and equip with the proper information on contraception and counseling. So everyone is requested to do a registration and a pre-test. And after the session gets over, you need to complete the post-test and the feedback. So you will be receiving the certificate of participation on attending the training, and submission of registration, pre-test, post-test, and feedback is compulsory. So in India, abortion is legal. Let us make it safe and respectful. Summer that is sustain, accelerate mainstream access to reproductive health thought health system. So Samarth Bharat, Sampurna Bharat. So thank you for patience hearing. And now I would like to invite Dr. Kiranmai Devinani. She is a professor in OBGY GMH, Vanapati, Kaloji University of Health Science, Telangana. And Madam is standing for the committee, FOXY committee. So no violence against women. And Madam, we are already doing many programs also, social awareness activity also. And we all support you, Madam.
Thank you so much, Kajal. I saw all your programs on March 8th and wonderful programs, and also very extensive and elaborate and wonderful presentations by both Dr. Jagrati and you. And I'm happy to be here at Vapi, though, and Valsad, though virtually. So thank you.
Thank you, Madam. In Surat also, Madam.
Yeah, Surat also. Surat, Dr. Jagrati is there, and
Yes, madam. Yes, madam. Welcome, madam.
thank you. Thank you so much. So, Shriman,
Ma'am.
I'll share the screen. There are two audio clips, video clips. I have to share the sound also, right?
Yes, madam. Yes, madam.
Okay, I'll try. If any problem, you just take.
Yes, ma'am. While sharing the bottom left, you'll have two check-in box, madam. Have to click on the two check-in box, then you can share your PPTs.
On the bottom left.
Yes, ma'am. Share with audio.
Share sound is there.
There are two check-in box, right, madam? Just click on.
Optimize for video clip is
Yes,
there.
ma'am. Yes, ma'am. Yes, ma'am.
Okay, done.
And after the video, madam, click on the right side arrow, madam. Then you'll move to the next slide. You don't need to come back.
Okay. No, while there is a video, what do I do?
After the video, you don't need to go back, madam. Just click the right arrow button. Then you'll move to the next slide.
Okay, thank you.
Okay, madam.
I'm not seeing the gallery or anybody else. I don't know why. Only the slide is seen completely. Shriman?
Yes, ma'am.
Okay. I'm not able to see the gallery or the other people on the sidebar. Why is it so? Okay. Okay. Hope my screen is visible.
Yes, ma'am.
Yes.
Ah, yeah. So we go to the module 3. As you must have observed, this module is combining the new MTP amendments that our government has given us, and also the WHO safe abortion values and respectful abortion, and also the counseling part. So this is all in one package in 4 modules. And also, I would like to say that our MTP amendment and law is one of the best and most liberal, and also which goes in line with the WHO and global recommendations for the human rights and women's rights. So it is very progressive, and we are all should be proud of it. So with this, I start this module 3, which is nothing but the safe abortion SAVER module. SAVER is an acronym which expands to safe abortion values, evidence, rights, and respect. So this is a joint FOXY and WHO initiative under the leadership of our President Dr. Shanta Kumari. Okay. So what is this module? The aim of this module is to define what is respectful abortion care according to WHO standards, and highlight how our own norms and stigma affect the services which we offer, and also provide WHO saver resources for the respectful abortion care. So we know that the momentum has been created and the law has changed. The new amendments have come, the gazette has been there, and now what is required is dissemination. I mean, that is what we are doing by means of these programs in all the societies. And because Foxy is the largest provider base for abortion care, and also online training is possible because of the COVID, and we have started last year itself. And MMA, that is medical abortion uptake, can be increased by early, safe, and ensuring that there is no PCP NDT conflation. And patient safety, respect, and quality matters more than ever now, and we all have a role to play. That is the purpose of this presentation. So what is respectful abortion care? The components are: we have to maintain the safety, dignity of the patient, and also confidentiality, as you have heard from both Dr. Jagruti and Dr. Kajal, that how we have to maintain the confidentiality, not mention the name and other details. And also we have to ensure freedom from harm and mistreatment, and we should enable informed choice and continuous support during and after all types of abortion. So all these components are there in respectful abortion care. In simpler terms, what we do is we treat them with dignity, empathy, and compassion, regardless of their race, ethnicity, gender, socioeconomic status, or reproductive history. Most of the times, we tend to have some bias as far as this reproductive history is concerned. Like if the patient is unmarried, pregnant woman, we do have some kind of bias. And suppose if she comes with repeated miscarriages, we do tend to have some bias, asking her why she is going for repeated miscarriages. So all these lead to kind of discrimination from our side without our knowledge. So as health professional, it is our duty to listen and support and have a good communication. So what are norms and stigma? So this is a small video clip. I thought this is very interesting and useful because most of the times we don't even realize that our feelings and our personal choices affect the care that we give to our patients.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID 19, there are new social norms that are considered COVID 19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others personally and professionally.
So that is it. Like we may have our own beliefs, which we feel that unmarried or premarital sex is wrong and all that, but that should not affect our care which we give to the patient or woman when she comes to us seeking abortion. So stigma and norms, what do they do? Because they perpetuate disrespect and abuse. So when we have this stigma and norms, we tend to show disrespect and abuse. That is why we had the WHO's video helps us to understand what are the types of disrespect and abuse that can creep in is depending on, we also know sometimes healthcare workers can indulge in physical abuse or shouting or intimidating physically. So the what is the right of the woman? It is a freedom from harm and ill treatment. So no one is supposed to do this. And then verbal abuse, shouting, screaming, and judging. And then sexual abuse, abuse of power and taking advantage. The rights of the women are right to information, protection under all the laws, informed consent, and the right to refuse contraception or abortion or any of the advice that we give. and she deserves respect for the choices and preferences, dignity and quality of care. And then stigma and discrimination, the saver video that we have seen, and failure to meet professional standards of care can also happen when we have this stigma and norms. This is also a kind of disrespect and abuse. Poor rapport also can be the result of this stigma and norm, and also is a category of disrespect and abuse. And also health system conditions and constraints. We know the constraints of busy OPDs, where there is lack of privacy, where we cannot talk in comfort, and we ourselves are stressed out, and we ourselves are suffer from so many limitations. So the right to timely health care and to the highest attainable level of health, liberty, autonomy, self-determination, freedom from coercion, these are the rights of every woman which we have to keep in mind. Then what, there are 12 domains of respectful abortion care. So again, free from harm and mistreatment, to be able to maintain privacy and confidentiality, women's dignity, choices, and engaging with effective communication. These are soft skills which all the younger generation and all of us have to develop. And then provide information and get informed consent. So not blanket consents, ensuring continuous access to support whether they agree to your line of management or not, enhancing quality of physical environment and resources, equitable abortion care, competent and motivated providers, contraception advice and commodity security at all stages of pre-abortion, during abortion and post-abortion. Again, Dr. Kajal will discuss this in the next module. Continuity of care and counseling at all levels. So this is the time to strengthen the implementation, because what has happened, from 2 providers now up to 20 weeks, it is only 1 provider, putting lot of more responsibility on this single provider regarding counseling, contraception, referral and compassionate care. All this has to be now done by this one provider up to 20 weeks. And up to 20 to 24 weeks, 2 RMPs are there, and beyond 24 weeks, we know that there is a medical board. And when there is 20 to 24 weeks, we know it is for the vulnerable groups like young people, unmarried women, rape survivors. So all these women need unbiased care, and we need to overcome our own biases in this special category. And here is the need for sensitivity and judgment free timely services. We should not postpone the abortion, we should not refuse the abortion, we should not judge them because of coming late, or choosing abortion, or we should not label them. This is where we have to keep it in mind. So confidentiality, safety, respect begets respect, and provide as providers we need to be mindful of all the socio-cultural aspects. So this is guide to avoiding stigmatizing language. I'll skip this because yeah, WHO training. This is an interesting toolkit. If some of you want to take this course, this is I think 2 hours or 3 hours. Sorry. Yeah. So 2-3 hours of course module is there on the site of WHO, which is called as Saver Toolkit. Just a little bit of.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Saver, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVOR is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So this is the SAVOR toolkit. You can explore on WHO. These are the links for the self-paced games from the SAVOR module. And then we have two recap questions which will kind of remind, or you can recollect the knowledge that you have acquired from the previous two or this third presentation. So from 1970s, from unsafe abortion, we have moved towards 2000, that is safe abortion, and now is the time for respectful abortion. So what are these recap questions? You please type in the chat box. I'm not able to see the chat box, but you please type. According to the WHO, restricting access reduces the number of unsafe abortions. Recently in our group, we had this discussion that if we go on increasing the gestational age and if we go on liberalizing the MTP Act, the number of unsafe abortions and abortions goes up and the contraception comes down. Actually, we might believe that it is true, but what is right is, does it increase or does it reduce? So the answer is false. So because whenever we restrict the access, what happens is the number of unsafe abortions goes up, not the total abortions. So by liberalizing or restricting access, we are not going to help anything. So the MTP Amendment 2021 requires a minor of less than 18 years to obtain written consent from parents and guardians before she can undergo a termination of pregnancy. Again, this question had a lot of confusion and difficulty in understanding. The fact is, it is not parents or legal guardians which is required. An adult who comes as a guardian, the written consent of that particular guardian is enough. So it is false, and but still we have to report through POCSO. It is still needed, but abortion services should not be denied. So, and we need to provide bias-free services without judgment. A 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Again, this part comes from my module, that is respectful abortion care. She belongs to a vulnerable group, that is 20 to 24 weeks. What have we learned? In this group, there is a lot of scope for judgment or disrespect or labeling, and we tend to get involved with a lot of biases. So it is not our responsibility to tell her to continue this pregnancy. We are supposed to provide respectful abortion care. Only thing is, we need to understand that 2 RMPs are required in this gestational age, but that is 20 to 24 weeks of gestation. That is the law. That is what we have to understand. So again, in India, abortion is legal, and it is up to us to make it safe and respectful. Samarth Bharat, Sampurna Bharat. So thank you for patient hearing. Yes.
Dr. Kajal, It is
Any
over to you.
queries, you please.
Yes,
type in
madam.
the chat
I'm
box.
here only. Thank you, Kiran bhai,
Kajal,
madam.
yeah, Dr. Kajal will continue with the fourth module that is very important, which is pre-abortion and post-abortion counseling.
Thank you, madam.
Thank you, Dr. Kiran bhai. Thank you so much.
Fourth one. This one, right? Counseling and contraception. Shall I start now?
Yes,
I'm audible? Jagruti, madam?
yes, yes, yes,
Yes.
yes.
So moving to the last session of the today.
Slide sharing is not, slides are not seen.
Slides are not seen.
Your desktop is only seen.
Now,
No.
Go back and start sharing again, madam.
Yeah, go back and put it. I hope it is minimized on the desktop, Dr. Kajal.
yes, yes. Just,
Yeah, I think you start again otherwise.
yeah. Yes, it is visible.
No.
Now,
Yes.
okay.
Yes. Make it full screen.
Yes, yes. Just a minute. You can see the slides.
We can see your slides. You need to make it full screen.
Yes, madam. I'm not able to see the other options.
Or you can start if the slides are seen.
Okay. So moving to the next session, that is module 3B, pre and post abortion, family planning counseling, and the different technologies and online consultation, respectful abortion care, joint FOXY and WHO initiative. So counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perception. Pre and post abortion counseling, integral part of comprehensive abortion services. It is as important as the procedure. Women may need help in decision making. Wherever needed, the spouse should also be counseled.
Kajal, just a minute. There's a dumbbell below you. Click on the dumbbell.
Where?
Here. Beneath. In the below on the screen. Near notes, comments, and there's a dumbbell. Yes, next to that. Next. On the right side. Right side. Still right side. Yes, click that.
Slideshow. Okay. Thank you, madam. Pre-procedure
It will
counseling.
still not become. Okay.
Done?
Okay, right. Yes.
Okay. So pre-procedure counseling, which is which plays a very important role and critical role. So help women decide about termination of pregnancy, help women to choose the method of termination, ensure delivery of complete information about the procedure, and help women to adopt a contraceptive method. Pre-procedure counseling ensure privacy and confidentiality, be non-judgmental and be sensitive, establish a rapport, use a simple language and allow the woman to clarify her doubts. If she has made up her mind for termination of her pregnancy, assess her for the procedure. Relevance of peri-abortion family planning counseling, quick return of fertility, minimum 6 months gap before the next pregnancy, opportune time for the contraceptive acceptance, and health benefits and better future pregnancy outcome. 90% of abortions related maternal mortality can be prevented by ensuring contraception. So what we need to include in the pre-abortion family planning counseling? When to start? First visit, consultation, exceptions, grief management, delay. What to counsel? About the importance that return of fertility will be within 10 days to 4 weeks. Help with the choices. Method specific counseling. What are the side effects? What are the failure rates about all the different modes of contraceptive devices? High risk behavior wherever applicable. If the woman is not willing for any contraceptive method, do not refuse MTP. Try and counsel her after the procedure. If she is still not willing, call her for the follow-up in a week's time and counsel regarding the contraceptive methods. Assessing suitability for the post-abortion contraception. General guiding rule: abortion process is complete, there is no existing infection, there is no injury to the genital organs, and chances of fresh pregnancy should be ruled out. Post-procedure counseling, which again plays a critical role, ensures woman has understood the precautions and care needed during the post-abortion period. Opportunity to counsel for the contraception in case not previously accepted, reinforce the need for continuing the use of contraceptive method chosen. Post-procedure counseling, continue to ensure privacy and confidentiality, reassure her in case of any problems, and repeat the information about post-procedure care and danger signs. Post-abortion counseling, already opted, then appreciate immediate care like IUCD or injectable method, ongoing oral pills, follow-up protocols, continuity, reproductive intuition, and cards. If she is undecided, LA, anxiety, importance of immediate adoption and chosen, extended period of adoption, couple counseling, and emergency contraceptive pills. What are the post-abortion contraceptive methods? First is a barrier method, that is condom. First trimester, as soon as sexual activity is resumed. Second trimester abortion, as soon as sexual activity is resumed. Additional information: no hormonal side effects. It can be used without consulting a health provider. Easily available. Prevention against STDs including HIV. Enables men to take responsibility of contraception. The other methods are intrauterine contraceptive devices such as IUCD 380A and 375, which can be inserted immediately or up to 12 days after confirmation of a completed abortion using the surgical method, with medical method of abortion inserted around day 15 of the process, provided complete POC expulsion is confirmed and risk or presence of infection or any other contraindication is ruled out. In case of second trimester, it can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. Additional information which we need to give is highly effective, provides a long-term contraceptive, maybe up to 5 years or 10 years. It can be provided by the trained doctors, MBBS and above, ANMs, nurses after the first trimester, surgical abortion by trained doctors after MMA, and by postpartum IUCD trained doctors after second trimester abortions. No interference with the sex, immediate return to fertility on removal, and no hormonal side effects. The other methods are hormonal contraception, that is OC pills, immediately or up to 7 days after abortion using surgical method. With MMA, it can be started on day 3 with the dose of misoprostol or within 15 days of the process after confirmation of complete abortion. In case of second trimester, immediately or up to 7 days after abortion. Additional information, regular menstrual cycles can be provided by all the healthcare workers after first screening by the trained provider. No interference with sex, offers protection against ectopic pregnancy, endometrial and ovarian carcinoma, and benign disease such as fibrocystic and fibroadenomatosis. Not suitable for women who are breastfeeding babies less than 6 months old. The other methods are long-term injectable metroxyprogesterone acetate, which can be given in the first trimester immediately or up to 7 days after abortion using surgical method. With MMA, it can be started on day 3 with the dose of misoprostol. In case of second trimester, again we can give her immediately or up to 7 days after abortion. It is highly effective. Confidentiality and privacy should be maintained. Can be provided by doctors, ANM nurses after screening by the doctors for the first injection. No interference with sex, no effect on the quality and quantity of the breast milk, no estrogenic side effects. It offers protection against ectopic pregnancy, ovarian cancer, iron deficiency, anemia, and uterine fibroids. The other methods are the permanent methods such as female sterilization, can be performed after an abortion in the absence of any infection or severe blood loss concurrently or up to 7 days. Both mini lap and laparoscopic sterilization can be done. With MMA, it can be done only after the first menstrual cycle. In case of second trimester, mini lap sterilization can be performed concurrently or up to 7 days after an abortion in absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended in second trimester abortion. Additional information, this is a permanent method of contraception, highly effective immediately, no interference with sex, no effect on breastfeeding, no long-term side effects, and it offers protection against ovarian cancer. Vasectomy, it is performed on the males independent of the timings and procedure of the abortion. It is very effective, permanent method of contraception, no interference with sex, no long-term health risk, and couple must use another mode of contraception initially. Contraceptive methods with MMA. So these are the different methods which we just now discussed. SRH services, teleconsultation and other technology. Leveraging technology, service provision, teleconsultation, telecounseling, teleguidance, telereference, and telelinkage. Now we have website like Hamdo, social media, Ask Tanu, YouTube, infographics, helpline, patient education platforms like WHO, MOHFW, and RCOG. Now SWOT on teleconsultation, it is strength, weakness, opportunity, and threat. So for the strength, COVID era, which we have now learned that everyone has become a techno savvy, and webinars at present also we are continuing with the webinars. So SWOT for teleconsultation, COVID era, approachable throughout the process, confidence, awareness, spread out the questions and answered at ease. Weakness, face to face, it is not possible like in teleconsultation. Demonstration, opportunities like privacy and comfort, cost saving, and number of visits are cut down. And threat is missed opportunity and misdiagnosis. Applicability of components of CAC, assessment, confirmed diagnosis, contraceptive need, counseling, video conference or on Zoom, and follow-up. We can have a hybrid services, 1 visit, or MMA, 3 visits. Key messages: realize the need of PFP, bring the couple on board and strive for 100% coverage, capitalize on the basket and applicability in PA period, technology as far as possible, scope for the entry in CSE services, concern, policy, malpractice, service cost and access, adolescent RH needs both online and offline platform, both. So registration and pre-test is must. Post test and feedback is compulsory, so you will be awarded with the certificate on attending the training and submission of the registration, pre-test, post-test and feedback. So thank you for the patience hearing. In India, abortion is legal. Let us make it safe and respectful. So Samarth, that is sustain, accelerate, mainstream access to reproductive health through the health system, so we can make a Samarth Bharat and Sampurna Bharat all together. Thank you for patience hearing. So here we end our sessions. All the 4 sessions are over. And you need to fill up the post test and the feedback form compulsory. So you will receive the certificate of participation. Anything else, Jagruti madam?
Any query? Yes, Dr. Kajal, I think you have explained in detail. So there are no queries here. So as you wish, if any of the attending members have any queries, they can put it in the chat box, I think, because we have.
I checked the chat box. There is no such questions. Yeah. And thank you, Dr. Kiranmai. Thank you so much.
Ma'am. Thank you so much. It was a pleasure to be with you all today.
Thank you so
Thank
much,
you, Dr.
madam.
Kuresha madam, Dr.
Privilege
Sheila
that you are
Moria.
with us. Yeah.
Acha.
Dr.
Okay.
Kuresha madam, Dr. Sheila Moria, I want to say something. Dr. Kuresha, she has joined. Even Dr. Sheila.
Yes, Dr. Sheila, I'm able to see.
Yeah, madam.
Yes, hello.
Yes.
Thank you very much for involving us also, Doctor. Thank you, Jagruti ma'am, Kajal madam, and Kipira ma'am.
Thank you, Dr.
For
Sheila.
your,
Thank you, Kuresha madam, for attending.
it was very nice to hear you.
For your support.
We will fill. We have filled up pre-test. I think we will fill up post-test also for our certificate.
Before we finish, I request, because I see Dr. Jagruti, Dr. Kajal, Dr. Sheila, Dr. Kuresha, everyone, please get schools involved for Dira program.
Yes.
You have done your March 8th program with such grand celebrations. So I request you to involve schools and let's start some
We have
schools.
already done our master training
Yeah,
program.
I know.
How
ma'am.
to start it?
No, that's what. So anytime I'm there, because the first thing is you have to give that president's letter to the schools and take date and time, what is convenient to them. Online, but because this COVID is gone, some of the people are doing it physical also, but the registration, pre-test and post-test has to be online. So once you fix the date, the DIRA mail, the central team will send you a registration link just as for this RAC. So the students have to open it, fill the pre-test and submit so that they get registered. There is no problem if they don't have email IDs. They can write just dummy emails like their name at gmail.com. No problem about that. So once they register, they'll send a joining link just as they have sent for RAC. So that joining link has to be shared with students. So if it is in the school you are willing to do, most of us are doing like in a big hall. We are projecting on the screen this presentations. We are projecting on the screen, and one of your members can go to the school to coordinate. So that becomes hybrid. Okay. So then once the registration is done, pre-test is done through online. Then once you get the joining link, that is projected onto the screen in the school in big seminar halls or conference halls. So all the students will listen at one time. After that, then again, Shriman or Ajay or one of us will provide the post-test links, which is again shared with the school students. They'll open it up and fill the pre-test and complete the feedback. And the certificates will be sent to you or school.
Okay.
In the
One more
certificate will
problem
be in
which we
English
are
language
facing.
only, na?
Certificate will be in English. Right now, we don't have option for other languages, madam. But
Yes.
once this first phase is done, we are trying. Actually, we made Telugu. Ours is Telugu language, so we made Telugu PPTs also. But it has to be, again go through UNICEF and everything, and they have to accept it. So right now, what we are doing is, though the slides are in English, we are talking in our own language,
Yes.
and it's
Yes.
coming good. Like they are understanding. We are to some children we are speaking only in Telugu, no English at all.
Yes.
So
Yes.
that is how. Ajay sir, good evening, good afternoon, good evening.
Good
Good
evening,
evening,
sir.
Ajay
Hi, good
sir.
evening, good evening. Yeah, good to see you,
Good
Kajal
evening.
Jagrati. Well done. And
Yes.
so good to see you, Kiran Mai, as
Sir,
usual.
I'm like propagating the Dhira school.
Yeah. That needs to be done. We have to reach a target of 250,
Yeah,
sessions.
because I see 4 or 5 master trainers here.
Hmm.
Yes.
All of them are master trainers.
If Kajal and Jagruti decide, they can do it. If they
Yes,
decide not to do
Yes,
it
sir.
because it is
that's the
Shanta's program, they
reason.
don't want to do it, they will not do it.
They'll do. The March 8th, they had done Dhira in a very grand scale.
Yes,
Yes, yes.
madam and
Yes.
sir. Just today morning also I took one seminar on this, but then there were more than 300 girls and boys. But I didn't knew that we can, register for the offline also.
Yeah, registration and pre-test, post-test have to be online, Dr. Kajal.
Okay,
Okay.
fine.
Rest, I think you can do hybrid is what is good
Yes,
actually.
yeah. I understood hybrid, but then, ma'am, again there is a time constraint is there. Like when we go physically, 2 hours, from the teacher side and from the school side, they are saying
Yes.
that if it is 1 hour, it is more.
I can
physical.
sit here.
Yeah. Hybrid is more convenient, and actually, if you can do entire thing online also, only one of us has to go there to coordinate.
Yes, madam. So we will do that also, hybrid.
Yeah, but if
Hybrid,
you've done 300 students, then you should have done it under the Foxy president, na? That's
Yes,
not
sir.
Yes.
That only I had a doubt, like, when we are doing offline, how do we register?
Then
So
you
just
should
now,
ask
Sir,
Kajal.
most of them are having this phobia of registration and pre-test and post-test.
I
Yes.
Otherwise,
cannot
they're all
understand.
experts in doing these programs.
actually,
I
sir,
can't
that
understand
place
what's
is
Exactly.
the
a very
yeah.
remote place,
Yeah.
and it is in a small, like,
Phobia is
very
something.
remote.
Phobia is for something very scary.
Hmm.
Phobia is not scary. We are not scary. Yeah.
The Dhira project is up to December 2022.
Yes.
Yes. So it is limitless. Like how many sessions we want to carry
No,
on. We can.
but Jagruti, it is not limitless. I will tell you the reason.
Yeah.
Everybody will then wait till December. And
No, yeah.
December, everybody will want to do. And then there are no slots.
Thoughts available.
No. I'm talking of physical. Physical we can carry on.
No.
No, physical
No.
also has to be in hybrid mode. Everybody
Okay.
who is doing the physical, you can do the physical. However, because it is a Foxy national program by the president, every student has to register
Right. Okay.
using the Zoom link.
Registration is only the problem.
Yes, you have to register using the Zoom link, after which you can do your physical.
That's
So
what.
excuse me, then you'll have to increase your slots.
Exactly. So you need to plan now.
Yes,
Yes.
sure.
Now.
Understood. Right.
Yeah.
Okay.
So
I mean, the first step is you get the consent from the schools. Later, we can guide step by step, no problem.
yeah.
Yes.
Get the consent
Okay.
from the schools, date and time, then we can go. I mean, it's not either Ajay sir or me can tell how to go about registrations and.
Have we finished the RSC program right now?
Yes,
Or
yes,
Yes,
sir.
yes,
Yes,
we have
sir.
finished.
Yeah,
okay.
we have
Yeah.
finished.
So what you can do is, and this is not just for the two of you, but everybody who's participating in this call, my humble request is to each one of you is to make sure that you reach out to the schools in your area or your, your own family members or your friends whose children are in school 9th through 12th, reach out to them and talk to them that there is a program of FOXY to stop violence against women. Rope in these schools, share Shanta's letter with all of them, share the entire plan with them. Basically, the plan is that we can do it in online mode, we can do in hybrid mode, we can do in physical mode. Online mode is national speakers will speak to the students through a Zoom. Hybrid mode is national and society speakers will speak to the students both online or physically, but the students will be physically present in the school. The complete physical is where the society members who are master trainers, for all of this master trainers is compulsory. All the master trainers can go to the school and conduct the physical session with the students sitting in the conference room or auditorium or wherever. But to do the physical mode, the students have to register, for which again we'll send the Zoom link. All the students should register because we want to show how many students we are reaching. We have to reach 5 lakh students throughout the country by December. Okay, so all the work that you all do will add to that 5 lakh number that we have to reach. So these are the 3 modalities through which each one of you can do it. Now, if you are not the master trainer, do not worry, because if you bring the school in, you become the chairperson of leading that entire program and guiding the master trainer. So you can do you can start the program with your inaugural speech. You can then invite the speakers to come and speak. And at the end of the session, you can give your closing remarks. So because you are closely involved with the school you have brought in, you should get the full respect and honor to lead the program. You may not take a session because you're not the master trainer, but that does not stop you from doing the program as the chairperson and doing the inaugural talk and the closing remarks. So each one of you have the opportunity to take it forward in your respective areas, in wherever you are working, wherever you are currently located. So please think about it in that fashion, that just because you're not master trainer does not mean you cannot participate in Dhira. Dhira is bigger than master trainers. Dhira is bigger than you and me. And Dhira is the one which we need to move it forward for the women of our country. Yeah, I hope that clarifies everything.
Sir, can I make them to today, which lecture I have already taken? So can I tell them to do the registration and everything after?
Yes, please do the registration. Yes, please do the registration and get the pre-test and post-test. Send me a mail. Okay. I will send the link to you for both of them. Yes, now, sir. The only challenge in your program which you did yesterday, because they will... Today,
yes, sir. Today morning only I did.
Today you did this program. While we will, it's meaningless to do the pre-test after the program. Yeah.
Okay,
right, because we don't know what is happening. What was their knowledge level before and what is after the training program.
Yeah.
Having said that, I still want to help you. Okay. Because if the student has attended the program and if you have taken the effort, so only this one time we will allow you to do that. Going forward, we will not go back. If you've done the program and if a student has not attended it, we will not be able to help them. We will not be able to give the certificate because that is the policy. And in your case, we will do this only one time. So please, everybody on the call, do not take this as the normal. This is not the normal. This is because we are special, request on the basis of which we are going to do this. And I have to give an explanation to UNICEF. So, and I do not want to spend my time giving explanations to UNICEF of why we did this or how we did this. Yeah, so I will tell them that this has happened. However, we need to honor the students who have attended the program because the effort has been put in by the faculty as well as by the students attending the program. So let's honor them and give them this. So going forward, please avoid such a thing so that, so that I'm not
it is a very remote place. So I thought then the network issues and everything will be there. So I was thinking of hybrid also. but it's a very small village type thing is there. So I
आजकल
just
गुजरात में विलेज बोलेगा तो it
sir,
is
एकदम ही remote place है sir, बहुत ही दूर है यहाँ से. It is
मोदी
almost
जी को
1
बुरा
hour.
लगेगा.
You are from
गुजरात is
Maithili's.
United States of America. हाँ?
All of them have mobiles and COVID में so online they were
Coding was there.
attending classes, no?
Yes.
About COVID.
Yes,
Thanks to
everybody.
COVID, everyone has access.
COVID has changed the
If
scenario.
Kajal was from Uttar Pradesh or Bihar, I would have kept quiet. Because there is a challenge there. We were there also, you know, it is difficult. It is not that they don't want to do it, it's difficult. But
Yes.
Gujarat, I will not accept that. Gujarat
Okay,
is
sir.
mini United States of America.
Thank you, sir. Thank you so much.
Thank you, sir, for
We are
So
motivated.
we are going to have Dhira school program from Gujarat.
Yes,
Yes.
great. See, Kiran Mai has been after my life. Sir, you are doing everything from Vijayawada. You are not doing for other states. Please help me to make Kiran Mai quiet. Please do it for my sake.
Okay, sir. Thank you so much.
In
Thank you, sir.
Gujarat, I have spoken to at least 10 people. Everyone has lot of schools, lot of approach.
See, Kiran Mai, we need to also understand with Gujarat, everybody was focused on the election of UP right now.
I know. हो गया ना election.
हमारा भाई लोग सू होवे, right? हमारा मोदी भाई लोग सू होवे. So everybody is focused there. Now with Modi getting everything, I'm sure these people will go all out.
Yeah, મોદી ભાઈ નું શું થશે?
हाँ, मोदी भाई નું શું થશે?
થશે. Right.
So now that we know he has won and he's on a mission,
Yes.
let's now make it a mission that Dhira also should fly high.
Yes,
So
let
I can
us make
see
it a
everybody
mission.
is listening in. Can we please put up videos so that we can quickly, Kajal or Jagriti, take a quick photograph and then we can close the session for the day.
Yes.
Can we
Switch
have
on,
your videos
switch
on?
on your videos, everyone. Please. Thank you so much. Dr. Ami.
just a minute.
Yes, thank you so much.
Yes,
Thank you
yes,
so much,
everyone,
everyone.
please.
Payal,
I'm taking a picture.
Rashri, Vaidehi, and there's
Shriman,
somebody.
Shriman, you also take a picture, please.
Yeah,
Yes, ma'am.
yeah, Meenakshi. Sriman, this time you also should come in the photo. Every time we only take our photos.
Dr.
Vaidehi,
Sir, I
Rajeshri,
joined, sir.
and there is somebody 0
Dr. Meena.
11396. Can we do it quickly, please? Can we do it quickly?
Dr.
please?
Kamala, please. Dr.
Yes, please.
Meena.
Can we do it quickly, please? Oh, so nice to see everyone. Namaskar, everyone.
Dr. Rajeshri.
Veena, Payal, Dhwani, Premlata, Zeel.
Thank you so much. Thank you, everyone.
Thank you. Thank you.
Thank you, everyone.
Thank you, everyone. Have a
Thank you,
nice
everyone.
evening, each one of you, on a Friday evening. All the very best. And I look forward to, Valsad and Vapi really taking the Dhira flag very high.
Surat.
Yes,
Reach
sir.
out. And
Yes,
do reach
sir.
out. Surat? How come Surat? This is
Yeah,
Vapi.
we are from Surat.
Oh,
No, we are from
Jagriti and
Surat.
Kajal are from Surat, sir.
अच्छा अपना ये
RAC में, yeah.
हाँ नहीं प्रकाश भाई
हाँ,
Yes,
Prakash Bhatt,
yes.
sir.
Prakash Bhatt, sir.
Yes. Prakash bhai and Asha Ben. Okay, great.
Yes.
Yeah, they are very good personal friends of mine.
Yeah. We are from Surat, Jagruti and Kajal.
Okay, great. So all the
Sir,
very
I am
best.
from Valsad.
अच्छा, you are from Valsad. Surat,
Yes.
Valsad, whatever you do, मेरे को एक वो जो गोटा का पैकेट है ना वो जरूर चाहिए. Next time I come.
Sure, sir.
Sure,
Sure.
sir.
Sir, you have visited every place in the country, every
Yes.
town,
Practically every town.
every town.
Yeah.
And you know all the languages.
Not language. I don't know the language. I just know a few words, but Marathi I know very well. And of course, English and Hindi, of course. Yeah.
Yes, say મજામાં છું. મજામાં છું.
Just speaking Gujarati.
And other bit I know, શું છે સારું છે.
મજામાં
કેમ
છું.
છો? મજામાં છો?
કેમ છો?
How are you? I'm good. Yeah.
Yeah, yes.
Okay. Okay.
Yeah, say મજામાં છું. Okay, thank you, sir.
All the very best.
Thank you, Ajay sir. Thank you, Kiranmai madam.
Thank you all.
Thank you, Kuresha
Have a
madam.
great weekend.
Yeah,
Yeah.
enjoy.
Thank you, Ajay sir.
Everyone, all the delegates, thank you for joining.
Yeah. Bye.
Bye, everyone.
Bye, everyone. Yeah.